Welcome back, everyone. Today, I have, again, the pleasure to have Dr. Makija, who is a renowned expert in osteoporosis and thyroid diseases, actually autoimmune thyroid diseases. And in our previous episode, we have talked about the most common questions about osteoporosis. Today, Dr. Makija is very kind to talk to us about 10 questions that are very pertinent to patients with rheumatoid arthritis and osteoporosis. Dr. Makija, welcome back.
Thank you, Dr. Garnita. Again, this is a great invitation and an amazing education platform that you've created. So it's all my pleasure.
Thank you. The first question of today is, can rheumatoid arthritis cause osteoporosis?
So quotations, yes, there is no answer for this question. And you want to be very, very aware as a patient, as a clinician, as a specialist that rheumatoid arthritis itself is a major risk for having osteoporosis, for having fractures, and itself will raise anyone's risk of further complications related to bone health. So definitely, yes.
Now, the second question that I have is, what are the 3 common causes of osteoporosis in patients with rheumatoid arthritis?
Mm-hmm. So rheumatoid arthritis, as Dr. Garnita can elaborate more on that, but it's basically, a systemic autoimmune disease, and it's mostly affecting the joints. And in medical terminology, the joints are called more, articular manifestations. So the disease itself, this autoimmune disease itself, is chronic inflammatory. So lots of inflammation. There's something called as pro-inflammatory cytokines, which are leading to bone loss. So they have a direct impact, or the disease itself has a direct impact on bone loss. Now, to give you an understanding, we tend to shed bone cells and make new bone cells, and we don't come to know that, like it's not a presentable symptom, or we don't feel it. So this is the process that rheumatoid arthritis as a disease is affecting and can lead to bone loss, specifically in areas where the joints are involved. So there is inflammation around those joints. So the skeleton in that neighborhood does get affected with low bone density. These patients are also treated with steroids, corticosteroids. So the longer the exposure of steroids, the more pronounced and rapid is the bone loss. Corticosteroids are notorious to have a negative impact on bone health, even though there is a great positive impact on addressing inflammation. There is commonly vitamin D deficiency in general population. And I feel it's more commonly seen in patients with rheumatoid arthritis. And, again, Dr. Garnita can elaborate on that if you have any tidbits. But that itself, if it's not treated, is another additional factor to cause bone loss and osteoporosis in these individuals.
Here, I have to agree with you. An uncontrolled disease and going on with inflammation again and again, or having long periods of untreated inflammation, that will lead, in my opinion, to faster development of osteoporosis. The second thing that you mentioned is the use of steroids. Yes, sometimes steroids are great. Patients are happy because that medication will release the pain. But if you use it for very, very long time in very, very high doses, then that would lead to faster onset of osteoporosis. And the third reason that you mentioned, vitamin D deficiency, I always check the vitamin D level in my patients, because patients with autoimmune diseases, we all know in our world, in your world and in my world, that vitamin D deficiency will increase the risk to develop autoimmune diseases. And actually, there are studies that show that vitamin D deficiency can actually perpetuate this, inflammation, and the immune system cells do not know how to respond in the context of vitamin D deficiency. So that's why vitamin D level is important in our patients. I often talk about supplements, as you mentioned in our previous talk, because I consider that supplements can be very helpful, but in certain situations, and it always they always have to be backed up by science. You don't have to take a supplement just because your neighbor takes it. You don't have to take a supplement because you saw it on advertisement. You have to talk to a physician that is knowledgeable, that will assess your risk and the benefit of taking a supplement.
Absolutely, 100% agreed.
All right. The next question is, when should you look for osteoporosis in patients with rheumatoid arthritis?
So if it's specifically timeline, there is no timeline. Earlier, the better, right? So if someone's just newly diagnosed with rheumatoid arthritis, while they are getting evaluated with their X-rays, with their series of biochemical evaluation, it makes sense in those next few months to just get a baseline bone density. And bone density is most of the times looking at the spine. So if I had to be even more specific, the lumbar spine and then the hips. In certain scenarios, these patients may need a forearm bone density also. So the timeline, as early as possible, get the screening test. If it's normal, great. They don't have an extra-articular complication as of yet, and the chances of preventing this condition is definitely higher. But if someone's already had long-standing history of rheumatoid arthritis and a very good baseline bone density, then a screening every 2 years is definitely warranted in these patients. And if they're on steroids, then sometimes more frequent bone densities may also be warranted.
You actually answer my next question. How do you diagnose osteoporosis in rheumatoid arthritis patients? There are different tools that you use compared to the other population, or you use the same tools. Can you explain to us?
Sure. The main tool, because that's what's FDA approved and recommended for screening, is the bone density with the help of a DEXA scan. Now, the tools that I additionally use is definitely the clinical risk assessment, what medications they're on for how long, and how long is the disease, right? And the severity of the disease. The next thing is we've had something called a trabecular bone score and a vertebral fracture assessment, which is incorporated in certain bone densities. So in Fresno, we do have those availability. And this is where specifically for patients with rheumatoid arthritis and primary hyperparathyroidism or a certain steroid-induced low bone density conditions, we look at trabecular bone score, which is basically microarchitecture of the bones. So how intact that is, how degraded that is. And then vertebral fracture assessment, just imagine you are, as a patient, getting the entire spine in one X-ray. And that gives us, a good idea of, are there any microfractures? Is there any change, which is called as a wedge compression fracture in these patients? Because that itself is a diagnosis of osteoporosis, not even including the bone density values. So those are the additional tools that are definitely well studied, well reported, evidence-based, that help us to treat our patients with osteoporosis in the population with rheumatoid arthritis.
How often should patients be tested for osteoporosis if they suffer from rheumatoid arthritis? Is there a difference between the general population and rheumatoid arthritis?
Sure. So you're not looking at the age criteria to screen these patients. You're looking at there is a diagnosis of rheumatoid arthritis, and if they're on treatment or they're not on treatment for rheumatoid arthritis, good to get a baseline screening test for these individuals. So same thing, bone density, look at the hip, look at the spine, depending on what the expertise is. If you need the forearm, definitely a vertebral fracture assessment for the first time will be a good baseline screening. If someone's on medications for osteoporosis, then we tend to vary it. Then it'll be between 1 to 3 years. So if my patients are on bone-forming medications, injectables, or even on steroids for rheumatoid arthritis, I may get a bone density done within a year. And usually, we have lots of recommendations to get the bone density within a year. When patients are on steroids, when they're on anabolic, that is bone-forming injectables, so that we are able to assess and look at the response sooner than waiting for 2 to 3 years.
Excellent.
Yeah.
Is In patients with rheumatoid arthritis, do you know if the spine or the hips are more affected? Is there a difference? What do you think?
So to again get a baseline understanding, we talked about in the previous lecture about females being more impacted with osteoporosis, but it's also true females do get impacted with rheumatoid arthritis. Like the incidence is more gender biased here, right? And then comes the menopausal or premenopausal, menopausal criteria also. So estrogen definitely has more impact on the spine. So lack of estrogen will lead to further bone loss in spine as compared to hips. Rheumatoid arthritis on top of it is also impacting the bone density in both the areas. But say if someone has hip arthritis because of rheumatoid arthritis, right? So there is chronic inflammation surrounding the hips. Then the hips are definitely more severe in terms of bone loss. They are getting more impacted. But in general, you would notice that lumbar spine, because of the gender, because of lack of estrogen, and now chronic inflammation or even steroid effect is more pronounced in spine, there will be a substantial reduction in those T scores and the bone density in these individuals. Rather than hips. But if hip arthritis is a common presentation for RA in a particular individual, then I do see quite a lot of bone loss in those bone density values also.
Good. Now, patients of mine, when I talk to them about osteoporosis and the risk to develop osteoporosis because they have rheumatoid arthritis, the next question that they have is can vitamin D and calcium supplements will help me to prevent osteoporosis? So that's the question. Can calcium and vitamin D supplementation prevent osteoporosis in patients with rheumatoid arthritis?
So we are addressing, we just talked about what is rheumatoid arthritis doing for bone health, right? So there's one arrow with the disease, one arrow with the steroids, one arrow with maybe the disease modifying agents that the patient is on, and then, lack of vitamin D. So just the fourth arrow that's being addressed with vitamin D and calcium supplementation, right? So it may not completely prevent the bone loss that is occurring because of the disease, because of the steroids, medications, or there may be some other autoimmune condition that the patient is encountering, which is still not addressed. So it may not be completely reversible or preventable just by calcium and D supplementation, but it is definitely a great adjunct. Now, studies have greatly shown that vitamin D and calcium supplementation can help prevent fractures, right? Now, they're not necessarily focused on spine or hip fractures, but they do help prevent fractures. But in specifically rheumatoid arthritis, one has to address all these variables which are impacting the bone health. So in short, again, I have a no and a yes answer. But definitely calcium and D supplementation needed. And I think from my standpoint, when these patients are being seen, we have variations, 800 units to 2,000 units as a daily supplement. But if someone's deficient beyond taking a daily supplement, they may need additional doses for their vitamin D supplementation. And calcium, be careful. Too much is not good. So staying in that 1,000, 1,200 milligrams in a day in divided doses, trying to focus on diet as then supplementation. So combination is definitely more beneficial. So excess or too less, no good.
Excellent. I'm so happy that you mentioned that because that's what I tell my patients. Rather than taking a supplement with calcium, look at your diet, bring foods that will bring you calcium, and even vitamin D, just a little bit. But even that will actually help you much more than taking a pill. Like we are both advocates of lifestyle interventions before doing medical interventions or drug interventions. The next question is osteoporosis treatment different in patients with rheumatoid arthritis?
So the treatment, offering a treatment is way sooner. So definitely the clinicians will have a lower threshold because having a rheumatoid arthritis itself is a check mark that yes, there is a higher risk for fracturing. Even if patients have osteopenia, it does
Mhm.
raise the risk of having fractures or worsening of the bone density in these individuals. So again, look at all the variables, look at the lifestyle, look at the supplementations. If that is all taken care of, then and still despite that the risk is higher, then yes, the threshold to offer them, have a discussion of what therapies do we have available or pharmacological agents we have available for osteoporosis would be way sooner in these individuals as compared to general population who are not encountering this specific disease called rheumatoid arthritis.
The next question is related to treatment. In your opinion, is there a better treatment or the best treatment for rheumatoid arthritis patients with osteoporosis, or what's your opinion about that?
Mm-hmm. Again, I would look at it's so patient focused, right? So it's
Yes.
never a generic guideline. It's never universal, one size fits for all. So severity of the disease and steroids. Okay, that would be the top two, main assessments as a clinician to offer the best treatment, right? So if someone had to really form bone, or if they've had a fragility fracture and no other contraindications, then anabolic therapy, that is basically a bone forming therapy, would be very beneficial for these individuals so that they do get a chance in next 1 or 2 years to build some bone rather than just losing or worsening of osteoporosis. If someone's just borderline osteopenic or low risk for osteoporosis as of now, then go for more simpler form of therapies. It could be oral medication. Some patients, premenopausals, I may even talk about hormone replacement therapy after assessing all their clinical risk factors. And then comes certain injectables, which is anti-resorptive. To simplify it, it is just stopping bone loss. Okay, so if you're on steroids, the severity of rheumatoid arthritis is pretty substantial, then you can even discuss anti-resorptive therapy, bone loss injectables, which could be once a year, 6 months, and now you're getting into nitty-gritty details of side effects, contraindications, what's the risk and benefit ratio here. So again, it's not one size fits all, but I would focus on what's the best for the patient.
I completely agree with you 100%. And that's what patient needs to understand, that they have to have this personalized approach, which they definitely find in your practice and in my practice as well, because there is not a guideline that applies to every single patient. They have to understand that there are certain risks that we think about, we discuss, we offer options, and then together with the patient, we should make that decision that will be comfortable for their mind, their approach, their cultural values, and go forward with that.
Mm-hmm.
My last question is, when should a rheumatologist like me refer patients with rheumatoid arthritis and osteoporosis to you?
So that's coming from rheumatology to endocrinology. So
Correct.
again, a great overlap. There is no timeline. So if there is quite a lot being handled by the rheumatologist in terms of rheumatoid arthritis treatment, right? Because there goes a lot with their biochemical evaluation, with their treatment modalities, then just ordering a baseline screening test. And if it is normal, lo and behold, you don't need an endocrinologist at that time point, right? But if it is suggesting even osteopenia, or if it is suggesting, just moderate to high risk, or if, many rheumatologists are perplexed that the rheumatoid arthritis is well controlled, the patient is very much optimized the lifestyle, and why is the bone density worsening? Definitely a referral to endocrinology would be warranted, because now we are looking to other secondary evaluations so that you are able to screen sooner for complications or for an etiology, rather than wait for 5-10 years before they end up sustaining a fracture.
Dr. Makija, thank you so much. Those questions are are absolutely vital for patients to understand how they should manage osteoporosis, especially when they have rheumatoid arthritis. Patients that have this disease, they are very, very welcome to learn from this. And if they need the help with rheumatoid arthritis, they are welcome. They are welcome to my practice, Rheumatologist on Call. But patients with osteoporosis that is not managed properly, was not addressed by the rheumatologist, they're very, very welcome to come to your practice and be assessed, get the personalized treatment, and get the care that they need to prevent worsening of their outcome and to prevent the development of fractures. Once again, Dr. Makija can be found in Fresno, California. And do you have any other tips how the patients can find you?
Sure, it's you can go to my website. It's www.unifiedendocrinecare.com, and no matter where you're in California, you're more than welcome to seek care or any form of second opinion. You can also reach me at an email. So it's hello@unifiedendocrinecare.com, or just follow me on Instagram, #UnifiedEndocrine. So any modality is completely welcome.
Thank you once again, and have a wonderful day.
You too. Thank you so much, Dr. Gurnita.
Rheumatologistoncall.com